This episode of Doc Talk is brought to you by First Bank. We're not just your neighborhood bank, we're your neighbors. Our local team lives up to the name, putting our customers and community first. To experience First Bank difference, stop by any of our 13 Knoxville area locations or visit firstbankonline.com. First Bank, member FDIC.
Hi, welcome to Doc Talk. Doc Talk, as you remember, is the Knoxville Academy of Medicine podcast that talks about health issues affecting all of us in East Tennessee, but we talk about it in plain language. That means no doctor language here. It's all something that you're going to understand. And today I have with us somebody who's going to talk to us about something called kyphoplasty. So while you're trying to figure out what kyphoplasty is or trying to Google it, try spelling it, is a radiologist, a new friend, who actually sees patients. I'd like to welcome as our guest today Dr. John Simmons, radiologist associated with Abercrombie Radiology Associates. Oops, there goes Henry.
Oh,
welcome, John.
Thank you.
Thank you so much. So what is vertebral augmentation, or some people call kyphoplasty?
So that's a good question. So vertebral augmentation is a general term.
Okay.
It includes vertebroplasty and kyphoplasty. They're two techniques done for patients with painful spinal fractures.
Okay,
And
so vertebra's in my spine.
your spine,
Okay.
correct. So if you have a fracture in your spine, in general, there are other indications we'll talk about. But for the most part, it's mostly osteoporotic fractures. When you have weakening of the bones in the spine, you get a fracture, it's painful. And we treat those to try to help you or whatever patient with the pain. And they're two different techniques.
Okay, so, it's everybody who is over a certain age. I'm not going to say that, lest I throw myself into the pot. Falls. And when we fall, we fracture our hip. And a lot of times we fracture our back and we don't even know it. And we just say, oh, my back hurts.
Absolutely. And there are many causes of back pain. And that happens a lot. And you may go to your primary care physician, or you may treat it yourself at home for a while. And it may not get better as fast as you would like. And then you end up going to your doctor, or you going to the emergency room or wherever. And
Need an x-ray.
you need some sort of x-ray, some sort of imaging study to look at it.
Okay. So I'm going to backtrack a little bit. What is a vertebra? Vertebrae.
Vertebrae. So your spine, our spine is made up of multiple bones.
I'll give you Henry.
Okay, so yeah, here's an example. Here's a miniature of a patient looking from the side.
Okay.
And so we have the cervical spine is at the top.
Okay.
The thoracic spine is in the middle.
Okay.
And the lumbar spine is so you have your
bottom.
neck, your chest, and your low back.
Got it.
Okay?
Okay.
And to make up that spine, we have multiple bones. In between the bones are the discs. Everybody's heard about herniated discs and that sort of thing. So they're little pieces of cartilage in between all these bones. And the vertebrae are the bones in the front. And we also have some bones in the back, so we don't just fall off. We're connected. And this allows us, because there are so many bones, this allows us to bend.
Okay.
And so when people fall, what they tend to do is they go like this or they go like this, and it puts a lot of pressure in the back, the bottom of your thoracic spine where your chest is, and usually the top of the lumbar spine. So it goes like this and it breaks one of these.
Okay.
There's 4 or 5 that tend to break most commonly. And it gives you pain in sort of the lower upper part of your lower spine, or the lower part of your thoracic spine.
Like right there.
Like right there.
Like right there. Okay.
And what happens is it's very painful initially, especially the first 2 weeks or so. When you break your back, it's going to hurt severely for a couple of weeks. And then usually it'll start to get somewhat better. And we tend to see patients, occasionally we'll see them within the first few days, but most of the time when people hurt their back, they either try to keep it at home and treat it themselves, which is fine, or they go to their doctor and their doctor will say, let's just treat conservatively to begin with and see how this does. And then if it keeps hurting, then they say, okay, we need to look into this further.
Okay. So
So
sometimes,
we can put Henry away.
it's interesting. So I know a lot of people who have they fall, they break their hip, they get the hip pinned, and they've been moving around on the operating room table and all of that. And then they wake up and they're supposed to ambulate, but they can't because they have this really, really sharp back pain.
Right.
And then maybe in the nursing facility where they're sent, then at that point in time, they probably ought to get an x-ray.
Yes.
Okay. And then, if we're not progressing, then something you can do can help with that pain. So at least they can start using their joint again, right?
Right. It's important that people stay mobile.
Right.
If you have a broken hip or you have a broken back and you cannot get up and be mobile, you're going to get sick.
Blood clot.
You're going to get sick. Okay, it's not good to be in bed. So yeah, absolutely. So that's one of the things. When elderly people break their hips or break their backs, it's not just the break that's the problem. It's the immobility. It's they don't eat well. They don't. So it's a whole cascade of things. So it's okay to rest for a few days. That's fine. But then if you're not getting up and around because of pain in your back for more than a few days, then you need to seek help. You need to go find out what's going on.
Okay. So we'd get the x-ray and we find out that vertebrals were broken, vertebrae were broken. So it can be, you call the ones that are thoracic, you call T something, and the ones that are in the lumbar area, you call L something. Is that
Yes.
how we?
So there are
Okay.
12 thoracics and there's
Okay.
5 lumbars, and we just number them.
So the report says, fracture T5, T11, 12, L1, 2, 3. Okay.
Yeah.
Okay. Then what?
Okay, so usually, whether you're in the emergency room or in your doctor's office, they will get a plain x-ray, the traditional x-ray that people are used to seeing. And often that will show if there is a fracture or not, but not always.
Oh.
Because what happens is if this bone breaks, it tends to lose its height. So I've got a little example here. So this is a one vertebrae, right? So this is the front of the patient. This is the back of the patient. The discs are here above and below. So what happens is that breaks, and we usually break it in the front, and the top usually breaks because there's pressure going like that. So it breaks the top and the height. So the height of it is usually this high. So it usually comes down. It can be severe. Severe is like this, moderate, mild. And so on an x-ray, you can see that. You can see the normal ones are here and these are down. What's hard to tell a lot of times in patients is that a new one or is that one they've had in the past that's healed? That's hard on x-ray to determine. Sometimes you can tell, but a lot of times you can't. So at that point, if it looked totally normal, your doctor might say, well, it looks pretty normal. I think we can continue to treat conservatively. If you're having very severe pain or you're having pain down your legs or something else, they might say, well, let's go the next step. And the next step would be a CT scan or an MRI scan.
Okay.
And that's another way to look at this and get a much more detailed examination.
Okay. And CT and MRI, they're not the same thing.
They're not the same thing.
Okay.
So they're both what we call cross-sectional imaging. So we can look at the body in cross-section like you're slicing a loaf of bread. CT uses X-ray. MRI uses radio frequency, and it's in a big magnet. There's no X-ray involved. So that's good. There's no harm in doing an MRI. There's no known side effect. There's some harm in X-ray if you get tremendous exposures, but for an elderly patient, that's really not an issue.
Okay.
What is the issue is that MRI is the most sensitive thing to do.
Okay.
It really is good at showing things that are swollen. So when you break your back, you get swelling. And MRI is excellent at showing that. CT is not so good at showing swelling. It's good at showing bone detail. So you will often see the fracture. But if you have a very minute fracture, it's still going to have swelling, but it may not lose that height. And you can have a crack that hurts a lot, but we don't see it on CT. So the preferred way to examine this is MRI.
Okay. Okay.
Everybody can have an MRI.
I know, and sometimes,
So sometimes
yeah,
you have pacemakers,
yeah.
you have wires here and there, and some people are claustrophobic and they don't want to get in there. So that's often we use CT, but MRI is the best to look at this.
Thank you. Okay, so the MRI then confirms that there's a fracture that's more than likely the culprit of the pain.
Yes.
Now, fractures will heal, but take some time.
Yes.
And so maybe something needs to be done to push it along a little.
Exactly. So here's what I tell patients when they come in to see me. The average patient comes in to see me, I'll say, what's your level of your pain? Okay, and how did this happen? But what's your level of pain? And for most people, it's severe. Now, I say, well, does that mean you can't walk? Often they'll say yes. Or I can only walk 5 steps and then it hurts too much. And I say, can you do your daily activities? Yes or no. Can you sleep? Are you able to lie down in bed? Some people have to lay in the recliner. It's so bad. So we try to get a sense of how much pain they're in. But also I tell people, so there are options now, okay? We can just continue to treat it conservatively, which might mean a brace around your back.
Okay.
It may mean using some drugs short term to help. It may need just more rest. But I tell people, usually there are 2 weeks of very severe pain. There's about 6 weeks of moderate pain. There's 6 weeks of mild pain, and then it's healed. So usually 3 to 4 months after you break your back, it'll feel better. Now that's not 100%, but that's usually the case. The options are then vertebroplasty or kyphoplasty to help that process, speed that process up. And we'll talk about how we do that, but the result is if we do that procedure and your pain is coming from that fracture, you're going to get better in 2 or 3 days.
That's great.
Rather than 3 months. So that's the beauty of that. Now, not everyone wants a procedure done.
Sure.
My mother broke her back.
Okay? So did mine.
And so did yours. Very common. The fact is, statistics say somewhere around 25% of females over 65 are going to break their back. 25%.
Something to look forward to.
40% of females over 80 are going to break their back at some point. 21% of males, 36% of males over 80. So it's a very common thing. Now, does everybody get treated with vertebral kyphoplasty? No. It depends a lot. It depends on your pain tolerance, depends on a lot of things. How many you have? A lot of people break more than one at one time. And you can imagine 2 hurts more than 1.
Sure.
So everybody's different. But usually when I talk to people and I say, okay, you can get better in 2 or 3 days, or you can live with this and slowly get better for 3 or 4 months, most people want to get back on the road.
I know, pretty impatient.
Yep.
So you do one of these things.
Yes.
It's pretty color. I'm going to give it to
Pretty
you.
color.
Better in your hands than mine.
Yeah. So, if the option is to let's explore treating this. Most of the time these days we do kyphoplasty.
Okay.
And originally this procedure, well, the first procedure done was vertebroplasty. The difference is kyphoplasty uses a little balloon that we stick in to the spine, and we blow this balloon up. It creates a cavity, and then we fill that cavity with cement. So both procedures, vertebroplasty, kyphoplasty, involve injecting what we call cement. It's not cement. It's the same thing they do with hips and knees, total hips and knees. It's a type of plastic, but we call it cement. So let's just call it cement.
Okay.
It's not out of the cement truck. It's sterile. But so we're injecting cement into the vertebral body. So where this is broken, there's little pieces and fragments of bone, and they rub and they move and they hurt. So we put one of these needles down when you're asleep, or at least very sleepy. We go through the skin from the back. It goes down into the bone, not through the bone, but to the into the bone. And through that needle, we put a balloon with kyphoplasty. We blow it up. We take the balloon out. We inject the cement into the middle of the bone. Sometimes we go one side, sometimes we go both sides. Just depends on where that cement goes. The cement is going to go fill the cracks. With vertebroplasty, you're not putting in the balloon. You just put in the cement without creating the cavity. Now, the beauty of the kyphoplasty is when this loses its height. If you do a vertebroplasty, the height's going to stay there. Whatever it is, you're not going to raise it up. It's going to stay where it is. Kyphoplasty, you take that balloon and it blows that up, and it'll take that squish, push it up, which will help straighten the patient. Because you've seen
Yeah,
the
we're
little
all like
people
this.
that are like that, right?
Yeah.
Exactly. Those people have had 6, 7 of these fractures. And every one, so they break in the front. And if you break 1, 2, 3,
It's the grocery
4,
cart
5,
position.
6, 7.
Yeah.
Exactly. So that's a problem. And those people have trouble breathing, they have trouble eating, etc. So you want to keep your height as best you can and your posture as best you can. And so kyphoplasty helps that. It doesn't correct it all, generally. It corrects some. But enough that that's useful. Also, creating the cavity, people think is a little safer in that you have a hole there that you can then fill with cement rather than the cement just kind of going where it wants to go.
That's brilliant. Because even more so in this day and age of our opioid crisis, if you can do something like kyphoplasty and alleviate somebody's pain, and then they're not dependent on medication, I think
Right.
that in of itself is a benefit.
I have to agree. There are people that need opioids for a short term to
Right.
get over this severe pain. Generally, once we do this procedure, they may need an opioid or some sort of pain pill for, I tell them, a day or two, and they should be done.
That's so cool. I'm so glad you joined us here today to talk about kyphoplasty. Now, I'm sure some of our viewers are going to have more questions. So, how do they get a hold of you?
There are a couple ways to get a hold of us. We do have a website that they're going to put on the podcast. I understand that they can peruse and get a hold of us that way. I personally work out of Tenova North and Turkey Creek.
Okay.
And we can be contacted that way. And your physicians certainly, usually people go to the ER or go to the physician, and the physician refers them to us. They don't generally come directly to us. Once they've had a fracture or we've been treated by us, then they can come directly back to us. They may get another one, and it shortens the process so they don't go round and round and round in circles.
And get stuck in the system.
Which happens.
All right, so there you heard it. Now you know what kyphoplasty is. Big word, but now you know what it is. Dr. John Simmons, thank you so much for educating us today. We look forward to more podcasts with you.
Thank you.
And that's a wrap.
This episode of Doc Talk is brought to you by First Bank. We're not just your neighborhood bank, we're your neighbors. Our local team lives up to the name, putting our customers and community first. To experience First Bank difference, stop by any of our 13 Knoxville area locations or visit firstbankonline.com. First Bank, member FDIC.